Please welcome to the stage Chief Medical Officer and Vice President for the Joint Commission Center for Transforming Healthcare, Dr. Erin DuPree.
Good morning, everybody. What an amazing kickoff to today. It's just great to hear about all of the improvement across the country. I'm excited. I hope you are too. And we have a lot of great things to talk about today to push that even further towards zero. Just to start, we have a patient video. So if we could have the patient video, please.
Hi, I'm Alicia Cole. I'm an actress. I live in Los Angeles, California, and I've been an actress. I've been in the Screen Actors Guild for 19 years. In 2006, I found out that I had fibroids. So I thought, okay, well, if I get these fibroids taken out in August, I'll be healed, I'll be ready for the start of the television season. I was supposed to be in the hospital 2 days in and out. I had the surgery, but I never got better. It just spiraled from there. My breathing started becoming very labored, and my heart rate just went crazy. My abdomen was flaming red, and it was hard like cement, and it was on fire. My mother saw a black dot, like you took a Sharpie marker and just gently went like that. It took the doctor about an hour and a half to get back to the hospital. And he said, oh my, okay, now we need to be concerned. The black dot was like the size of a quarter. It looked like my skin had melted. He looks at my mother and he says, Mrs. Cole, are you squeamish? And my mother said, no. And he said, good, because I need you. I was terrified. To ask my mother to assist him and not wait and take me back to the operating room in a sterile, clean environment, to take a tray with gauze and put it in the windowsill overnight, and then take that same tray, lay it across my legs, and start pulling gauze out of an already open box. And they basically use their hands to pull open my incision. I've never felt that kind of pain, ever in my life, ever. The infection was spreading about an inch every hour on the surface, so even more underneath. So the infectious disease specialist should have been there that night, but she didn't come until the next afternoon. No one really paid attention to the signs and symptoms that I had. In that hospital, starting from the top down, there was a lack of consideration for the patient. It wasn't until after that, a few days, that the doctors verbally told my parents what I had. Sepsis, Pseudomonas, VRE, MRSA, and necrotizing fasciitis, flesh-eating disease. It was an indication of a total system breakdown. I was in a prominent, beautiful facility. I did my homework. I did what an engaged patient is supposed to do. I was proactive. But my 2-day hospital stay for routine fibroid surgery went from 2 days to 2 months in the hospital, a month in ICU, 9 blood transfusions, 6 additional surgeries, almost having my left leg amputated. I had a year and about 2 months of twice-a-day home health care nurses. I had an open abdomen for 3 years that would drain. Physical therapy off and on for at least 4 years. Doctor's appointments every week for the last 7 years. And over $2 million in medical bills. I used to have a lot of faith in the system. When I see what's happening in healthcare and people who it's just a job and coming to take care of a woman who's missing her abdomen, and I don't bother to read her chart before I get there. or I don't bother to wash my hands. That kind of thing hits me at my core because it's not how I was raised or who I am. We believe in honor and loyalty and truth and standing for something, no matter what the cost. My life is completely different. It's, I was a cheerleader, volleyball, basketball, softball, ran track, bowling, you name it. So that's real hard. I had the most amazing support system going through this. It's what saved me, literally what saved me. There are so many patients who are by themselves, and that's why it's so important to me to speak out, to advocate, to give back. And I'm very, very proud to have been a part of the 2 laws for public reporting of hospital-acquired infection rates in the state of California. Our hospitals are scary places. Our healthcare system is broken, but there is hope. And that hope is patience, patient engagement, patient involvement. Albert Einstein says, you cannot fix a problem with the same mindset that created it. Patients bring a fresh perspective. We are the secret weapon, the magic bullet. Patience will change healthcare.
I'm sure there's not a dry eye in the room. Very powerful story. Thank you, Alicia. We have a great panel lined up, and I'll introduce them in a few moments. And, Alicia's story, I just have to stand back. I'm an OBGYN, an obstetrician gynecologist, and I've on rounds, changed dressings, have seen patients with open abdomens in the office, and each patient, 15 minutes of my day, they're living with it 24/7. And we as practitioners, it's bringing the patients into these conversations. It motivates, I think, all of us. It certainly does for me, and brings it does bring a fresh perspective. We're all here to prevent one more death, one more life, one less harmful event. And one of the best ways we can do it is with patient advocates. One of my teachers, as I was training, actually taught me that the biggest change in obstetrics over the last 50 years was not the advances in neonatal intensive care, not fetal monitoring, which didn't exist long ago, not the fancy sonograms. It was actually having the father in the delivery room. So all of a sudden, the patient who was in pain couldn't focus on what the physician or nurse was saying, actually had an advocate there. That changed the communication, the way that we as obstetricians communicated with people. And that's at the heart of some of the panel and work that we're doing that you'll see later as Alicia and the rest of the panel comes up. If we could go to the next slide. Oh, I have a clicker, thank you. So I'm going to walk through. This audience knows about healthcare-associated infections, but I do want to do a touch of level setting and make sure we're all talking about the same thing. There are infections that occur after exposure to healthcare, often but not always as a consequence of this exposure. And it doesn't just include infections in the hospital. It's infections in the nursing home and other healthcare facilities. You read about outbreaks sometimes in the news, right? Endoscopic sterilization failures in New York City in 2001, in Nevada, 2008. Syringe reuse transmitting hepatitis C in a pain clinic in Oklahoma. And what about listeria in the hospital sandwiches in the United Kingdom? In these outbreaks, what they've found, detailed investigations, I mean, all hands on deck when that kind of thing happens, right? What's going on? Is this going to spread further? Let's contain, mitigate. What happened? And we find obvious violations of basic infection prevention practices in all of these situations. And it turns out the healthcare practitioners weren't really aware that their practices were in error. They're so used to going about their business in the way that Alicia so eloquently described. They don't even realize or have the awareness that they're not practicing proper hand hygiene, that they're not changing the dressing in the most appropriate way. But those are just the tip of the iceberg, right? It's the endemic healthcare-associated infections that are really the brunt of the problem today. It's those device-related ones, the catheter-associated, the central line-associated infections, the ventilator-associated pneumonias. And it's the procedural-related, the surgical site infections. All of those together make up 80% of healthcare-associated infections. They're a major global problem. They are among the leading causes of preventable deaths. It's estimated that these occur in 1 in 20 hospitalized patients in the United States, resulting in 1.7 million HAIs. 98,999. Thank you, Joe. I think he just left the room to talk to Patrick a little bit more. But it's 98,999 plus 1. But it's ultimately, statistics unless it's you or a family member, right? Or a loved one close to you. In developing countries, the burden is even greater. We don't even have good estimates because the surveillance is so poor. The economic impact is tremendous. I don't probably have to speak to this audience, but Zimlichman actually published a recent systematic review that put it at $9.8 billion. And you'll read other reviews at different numbers. This is likely a conservative estimate. Other methodologic and epidemiologic approaches to that estimate put it as high as $45 billion. $45 billion. And if we put just 20% improvement around infection prevention, we could save the system, direct hospital costs and others, $6 billion. If we improve things by 70%, we could bring that up to $32 billion. On a per-case basis, central line infections are the most costly. Surgical site infections contribute the most, though, to that overall cost, a third of the cost. And we certainly have made progress. I mean, you heard some of the great stuff, kicking off with Peter Pronovost's work and a lot of the spread that was brought in to CMS with the bundles and the spread of that approach. We have gotten somewhere, but not enough, not fast enough, and we're not at zero. We know that adherence to infection control practices is incomplete. The World Health Organization for Patient Safety, the Alliance, was formed early in the 2000s, both in developed and developing countries. And their first focus was infection reduction. And with that, they focused on hand hygiene. They advocate clean care is safer care. We know what we have to do. It's not a mystery anymore, right? The lack of consistent hand washing pervades everywhere. A recent study in Pakistan showed with a hand washing approach that they were able to decrease childhood pneumonias by 50% and diarrhea in kids under 15 also by 50%. How many childhood global deaths could hand washing actually save? It's tremendous. As Joe had mentioned also, Semmelweis is really the savior of mothers, an obstetrician who found that going from the morgue to the clinics, if people just wash their hands, decreased the incidence of morbidity and mortality to those mothers. We've known it for a long, long time. We just have to take the next step. Beyond the bundles, the spread that's occurred, how do we continue to get to zero? Antibiotic stewardship is something we haven't really touched on yet. We do a very, very poor job in this country and elsewhere around the world of really giving the right antibiotics to at the right time for the right duration. And we know that antibiotic stewardship saves lives and saves money. At the University of Maryland, one institution, over 8 years, they published this, they found that they saved a total of $17 million over 8 years. They stopped the program 1 year. Unfortunately, it increased. Their costs went up by $1 million the minute they stopped that program. It's exceedingly important. We have to act now on antibiotic stewardship. It's important for all of us to work together on these issues and inspire the necessary cultural change. That paradigm shift, which we've heard about many times here already this weekend, going from that thinking, which is still pervasive in healthcare across the country, how do we get from the thinking that many infections are inevitable, maybe we can prevent some of them, to each assuming that each and every one is potentially preventable unless proven otherwise. We've gotten so far with the improvement, a lot of great improvement, a lot of good engagement across the country, but we're still not there. We still have a lot of work to do. And where do we go? What is the solution? How do we change the mindset of the many, many institutions and many people that don't understand this and aren't there yet? It's an approach to improvement. That is the solution. It brings in leadership commitment, which is number one. You have to have that. You can make some progress. A unit can work on bundles and get that in place, but to drive it even more and understand what's going on, you need that leadership commitment to help support the frontline workers. You need that environment of being able to speak up, to understand what's wrong, to want to learn. A learning environment is part of a robust approach to improvement. This is what will transform the system, is that type of approach to learning, one that focuses on data, that's data-driven and understanding the whys. And that is what is going to engage all of the frontline staff. That's what's going to make it fun to come to work, to see the joy of those numbers going down, less infections, looking at data, understanding what we're doing, how we can change, making it doable, integrating it into the workflow. It's that type of partnership that can transform the system. And what's inherent in this approach to improvement is that the patient is the focus. That's what it's all about. So, I've been fortunate to be part of and lead many efforts. I was the chief medical officer at a major academic medical center in New York City, and this is the type of approach I used with everything I did across the institution. We were able to decrease surgical site infections in open heart patients by more than 50%. It works, but you need all of the components. And you'll see on today's panel, we actually don't have an infectious disease expert, right? It's a healthcare-associated infection panel, but where's the expert? Well, we know what to do. It's about leadership. We have board member, CEO, chief medical officer. It's about an approach to improvement. We have a specialist in quality improvement here. And it's about having the patient as part of the conversation, part of the team. And Alicia's part of our panel, too. So I'm going to introduce the panel, and we'll take it from there. So first of all, we have Dr. Michael Shabot, System Chief Medical Officer at Memorial Hermann. Michael, come on up. Alicia Cole, Patient Safety Expert. Robin Betts, Assistant Vice President, Quality and Patient Safety at Intermountain Healthcare. Thomas Priselac, President and CEO of Cedars-Sinai's Health System here in LA. And Sharon Rossmark, Vice Chair of Sinai Health System in the Chicago area and Chair of the Patient Safety Board Level Committee. Is everybody comfy? Yeah.
Yep.
So, Michael Shabot, you were certainly the star of the presentation earlier today. So I got to start with you, and all of you are stars here. We're going to get to Alicia and everybody else. I mean, the star-studded day is beyond. But I'm going to start with this question. What are the clinical and financial implications of HAIs for patients and organizations?
Well, thanks. It's a little off topic, but one thing I've learned is that I need to be very careful in my personal emails to Dr. Chasson. Just never know where they're going to appear. But I think the implications are really personal, and Alicia has said that better than anything I could say. I am a surgical intensivist. I dealt with hospital-acquired infections all my life. For a significant part of my career, as you stated, we thought they were inevitable. They were like acts of God or acts of bad luck or whatever you want to call that. And it was only in the mid-2000s that we learned that these were actually preventable and that the source of these infections were bacteria and other organisms that we actually carried into central lines and into surgical wounds and to ventilator tubing based on our actions. And that was a heavy, heavy realization. I think the best data that I'm aware of, the earliest data, came from Pennsylvania. And if you type PHC4 into Google, you'll get their hospital-acquired information data and actually other data all the way down to individual physicians without a password. And from their 2004 data that was published in 2006 showed that about 3 to 4% of their hospitalized patients had a hospital-acquired infection. That raised, any hospital-acquired infection raised the mortality rate 800%. Bloodstream infection raised the mortality 2,000%. And the cost of care just went up by multiples. So there's huge implications for patients, for hospitals, and actually for caregivers. And I just want to tell one story from our Southeast hospital. We have hospitals all around Greater Houston, kind of named by location. And we have in each of our 3,500 patient rooms around the city, we have a large sign for patients and families in 2 languages, and about how they can help with our safety and high reliability campaign. And the first instruction is for each patient and family to make sure that every caregiver and every person coming into the room washes their hands. And there are others, and it ends with the phone number of the rapid response team. And at that hospital, a patient took that to heart, and her physician came in the room and didn't wash his hands. And she asked him to wash his hands, and he laughed it off and said, "My hands are clean." She asked him again to wash his hands, and he refused. She fired him on the spot. This is a true story. I called the nurse manager, called the chief medical officer, had that physician replaced. I can assure you that within 24 hours, every physician at that hospital knew that story. And actually around our system with 6,000 physicians, most of them heard that story. But the other part of this is that for all of our hospitals, we have a scoreboard for their HAIs, and we have a system scoreboard. It comes out every month for each hospital. And it's like a baseball scoreboard, and there's no denominators, it's just numbers. And our Southeast hospital was our very first hospital this last year to zero out, this is kind of incredible, even to me, all HAIs, bloodstream, urinary tract, surgical site, orthopedic implant, ORIF, MRSA, C. diff, 0. There were whole hospital 0. That was that same hospital, and the patients and the doctors helped.
That's great.
Sharon, in your experience, well, first of all, maybe you could describe your role as a board member and your involvement with patient safety, and then tell us how the problem of HAIs really came to your attention.
So as a board member, my primary role, not only as vice chair of the board, but then also head of patient safety, is to send a signal throughout the organization that the board owns patient safety and is very serious about patient safety at our organization. So the issue for us around HAI first came to our attention via, of course, a management update and one of our dashboards, what we call a Go Green patient safety dashboard, except for the green started changing. We started seeing pockets of yellow and red. And the board started asking questions. And we weren't happy with necessarily the responses we were getting, primarily because we didn't understand. We didn't take the time to seek to understand. We just wanted it fixed. And that wasn't the right approach. So as I look back now, 5 years later, what's different is there's more of a dialogue and less passive acceptance. Clinical chairs come in and they actually present to the board what the issues are, sentinel events, all critical events, and they cover with us process of improvement and how it's going to change in the organization. And so the bottom line is that the board now demonstrates that it owns patient safety, and we expect results.
Great, thank you. Alicia, as someone who has experienced HAIs, including MRSA, VRE, Pseudomonas, and ultimately sepsis, how does an experience like that change a patient's life? What should caregivers and healthcare leaders here today understand?
Well, one of the things you left off with was the necrotizing fasciitis, which was the killer of the killers of the whole thing, because there's nothing like being eaten alive. And then there's nothing like being eaten alive when you know it was preventable. And to your example, I wish I could say that that was an aberration and a rare occurrence where someone doesn't wash their hands, but that's a common thing that patients experience. And it's a common reaction when you ask a healthcare provider to wash their hands. I mean, I've had people roll their eyes in my face. I've had healthcare providers say, go into this long explanation about I washed my hands before I came in, and then I have to say, well, yes, but then you touched the doorknob, and then you touched the drawer, and you opened it up, and now you want to touch my abdomen. And you end up getting into these debates. And it's one of the reasons why patients are reticent to speak up, even if you say it politely, because you get that pushback. And what I'd like healthcare workers to know is that for you, it's an inconvenience. For a patient, it's life or death. That's the difference. And so when I speak with patients, I try to empower them. You are taking your life into your hands just by asking someone very politely to please wash your hands. To your point about life after, we hear a lot about the numbers of deaths from hospital-acquired infections, but we don't often talk about the 2 million patients a year who get a hospital-acquired infection and what that means. I would like to see quality of life as an outcome measure. I would like to see hospitals have to follow up with those who have had a hospital-acquired infection a month, 2 months, 3 months out. I couldn't wash my own hair for like 2.5 years because of my open abdomen and packing, and I had nurses that came in the morning at 7 a.m. for starting out as a 2-hour dressing change and progressively getting less and less, but I only had a small window to get in the shower before they came. And to raise my arms up like that was just a major feat. So little things, couldn't vacuum, couldn't bend and clean. My abdomen, when I would even just walk too much to try to ambulate, or if I sat like this for any length of time, my leg and my stomach, because they were going to amputate this leg, and so the wound came down about 2 inches on the top of my thigh. They would fold onto one another, and when I stood up, they would rip back open. So when you talk about quality of life, everything changed. Even now, to get through the day, I mean, I'm gonna stand up, not being fresh with you. But, you know, survivors have to make compensations just to get through the day. You have to wear a heating patch because if I get cold, this leg goes numb. Because I've got nerve damage in my, adhesions around my nerve bundle and my groin. People are wearing colostomy bags underneath their clothing. I wore maternity pants up until this past Christmas. My dad said, if I have to look at you in a pair of maternity jeans one more time, you are going to the store with your mother and we're going to find some of those stretchy jeans. So, there are so many adjustments that patients have to make after an infection, even if it's not one as severe as the one that I had. And we need to start measuring that because just because you made it out of the hospital does not mean you had a good outcome.
Well said.
Tom, as a CEO, aside from the clinical benefit to patients, why is it important for you to lead an HAI initiative?
Well, first, I think Alicia's comments and I think a theme that we've all heard already is, we can't go past the impact on the patients first, and let's all acknowledge that there is literally nothing more important than that. In fact, as I think about my answer to your question and its kind of organizational element, it seems so meaningless, to tell you the truth. But I guess the way I answer your question is I'm a strategic planner by original training. I like to say I'm a recovering strategic planner. But in terms of the importance to the institution, it is central to what it is that we've set out as our mission and vision. Our goal is to be among the leading institutions in the country. And you can't do that without being a leader in this area that we're talking about. For us as well, especially in the case of Cedars-Sinai, the nature of our organization, our mission and purpose is such that in today's world, in today's value-driven world, our ability to be able to care for each and every patient with essentially a high reliability environment and zero defects is essential because we're not the least expensive hospital in America. We provide the most advanced, more of the most advanced medical treatments in heart disease, neurosciences, organ transplantation, high-risk obstetrics, et cetera. And so the patient care elements of what goes on in the organization, our teaching and research mission makes us expensive. In a value-driven world, in the end of the day, people have to know that it's worth it to come to Cedars-Sinai versus another institution. And the ability for us to deliver a safe, high-quality environment where the patient has the right outcome is central to that.
Thank you. Michael, I'm sure your organization didn't start there. I mean, what was the mindset you were facing when you started this journey? And at that time, what was it like? What were the hurdles you were facing and how did you approach them?
Well, let me acknowledge that that mindset really started at Cedars-Sinai working with Tom and colleagues there. I directed and ran surgical intensive care units. I did surgery, operated for necrotizing fasciitis, very challenging. But our mindset was, as I kind of indicated, these were, and you said, and these were kind of inevitable. And then we found that they were preventable. With bundles and checklists and prevention of contamination of these lines. And we actually started that there and implemented that through all of the ICUs at Cedars-Sinai before I left at the end of 2006. And So that was very important, and we saw the rates begin to fall there. It was when I got transplanted to Texas, to a system that had experimented with bundles and things like that really had not been implemented. To tell the God's honest truth, I just took the things I learned at Cedars and put them in system-wide there, but not just in the ICUs, but on all the floors and all the units. And I think Dr. Chasson showed one of our slides, but just implementing the bundles dropped the slides for adult bloodstream infection, NICU bloodstream infection, look exactly like the ones for the ventilator-associated pneumonia that Dr. Chasson showed. They just had a rapid drop. So a change. This was a whole system-wide change of mindset. 20,000 individuals, which, as I'll probably get a chance to describe, was in the context as time went on of actually becoming a high reliability organization. That can't be done if HAIs are rampant. HAIs are so devastating to individual patients, so devastating to your outcome statistics, whatever they are, and actually so devastating to cost, both on a patient level and on a system level. We actually measure those costs every year and remeasure them. And I can just tell you, this isn't secret information, we don't publish it, but an adult bloodstream infection costs us just under $37,000. A neonatal bloodstream infection, which are thankfully now very, very rare, $62,800. A little under 30, about 35,000 for a ventilator infection, in the 20s for surgical site infection, depending on the type of site, and around 6 to 8 for a urinary tract infection. So we actually keep track of those, and again, part of our monthly operating metrics for every hospital is their actual scorecard of those costs for a month and for the year. And of course, 0 is a really good number because it multiplies nicely into 0. Yeah.
Can I interject? I have a question, and from a patient perspective and what I've seen. Now, we talk about the cost of hospital-acquired infections. And when you're dealing with Medicare patients, we understand that there's a cost, and that I'm very happy, so happy, that Obamacare is now saying quality is going to be a measure of how much you are reimbursed. Because when we as patient advocates look at costs, we think perverse incentives. Because when you're talking private pay insurance, and I had Screen Actors Guild Plan 1, which is the best insurance out there after the Directors Guild and the Producers Guild. Sorry. Okay, so it's private payer. If I had been a Medicare patient who had this horrendous thing happen, my hospital would not have been reimbursed. However, before I even left the hospital, I was getting past due notices on bills that were coming in that said $750,000. I'm in the ICU and my mother is coming crying like, oh my God, are they gonna put you out? This is $750,000. My hospital was able to bill and receive payment from my insurance company for close to $2 million before I ever even left the hospital. So I was a cash cow that kept going. Phlebotomy got paid, diagnostics got paid, hematology and oncology got paid. Everyone made money and generated experience off of my infection. So it was a perverse incentive. And where patients come in with excellent multiple insurances, and they are just, they're an ATM. And until private pay insurances follow suit with the government, with Medicare, and they say, we will no longer pay you for a hospital-acquired condition, for necrotizing fasciitis, for hospital-acquired bed sores. We're not going to do it. We really need to see that happen in this country, and this whole conference will be about 15 minutes long. We'll show up and say,
Here, here.
If I could.
I want you to do it, yeah. Tom, could you
Yeah,
please
well,
add on to
I just
yes,
make the
yeah.
observation. Actually, I think you're two things. One, your wish is coming true because I think that actually is the evolving policy position. But your question also raises another opportunity, I think, and to show how, from an organizational standpoint, you have to align your behaviors within the institution to be fully supportive of this. So in our case at Cedars-Sinai, I'm sure probably at Memorial Hermann, many other organizations now have in fact adopted a policy that where an individual does have the kind of experience you had, that individual not bear the subsequent cost. And they and their insurance company not having to bear that additional cost. So you have to align all of your motivational systems within the organization.
Let me just add another way that that's coming true. And I think it really was a perverse event, and it kind of inhibited, action to reduce not just this, but all kinds of errors in healthcare. But Memorial Hermann's formed an accountable care organization. It currently has 40,000 Medicare patients enrolled, 260,000 private, and about 50,000 of those are our own wholly owned insurance company at full risk. So there is no compensation for errors, accidents, hospital-acquired infections, whatever. And I think that, as Tom kind of indicated, your wish is coming true. The axis of insurance is being shaped as we speak in ways that are actually very hard to predict. But what's clear is that the risk is coming back to the caregivers. Right. And we will own it all. And we're the kind of initiatives you're hearing about at this meeting is owning it all.
Right.
And along that same line, as a safety net provider within the city of Chicago, we already have that issue, and so we have to own it. So we have no choice but to fix this, not only because lives are at stake, but because many times we don't have any reimbursement coming in because they're either uninsured or they're Medicaid, and the percentage is just not there.
Robin, the frontline staff has so many competing priorities, right? Their days are so busy, so many processes. How can they keep this at the top of mind? How do they remain aware of every single time that they touch a drawer, that, to wash their hands?
Yeah, I think a lot of it, most of it starts with leadership. So for example, with our central line associated bloodstream infection goal, we made it a system-wide patient safety goal, making it a leadership and management priority. And then that way we were assured that our line staff would be afforded the tools and resources and support that they would need to be successful. We also let them own the improvement. Each unit across our 22 hospitals had a unit champion. They conducted a gap analysis and practice against the best practices. We already know what to do, but are we doing it right in our unit, every patient, every time, or do we have variability? From that gap analysis, they developed their unique improvement plan for their unit. We set up a website, an interactive portal, where their plans were posted and updated monthly, and they were held accountable through that, as well as celebrated their improvement. Other things that we did was we provided metrics that were posted in their units every month, and so that they could be further incentivized and motivated by the improvement. Some units posted days since last infection, and they were posted in public places so that they weren't only held accountable to their peers, their healthcare peers, but to the community as patients, families, and friends came into those units. I've had several patient advocates from this event share with me, well, what do I know? I feel like I can contribute so little. I think what you contribute is invaluable, but I think we as healthcare leaders, we need to not be afraid at looking inside. I could certainly borrow Alicia's video and show it to my staff, but I went through great strains this year to get approval from my legal and risk management. We filmed our first video. We stole somebody's child. We took their life, and the Ramals are beautiful people, and they shared their life, their loss, and that video will humanize every activity, every task that our nurses perform. I want it to be a human intervention, not a task to check off. And that's how we keep it very personal. I have a neonatal intensive care unit. It's a level 3, so high acuity unit that has had 1 CLABSI in 5 years. It's very personal for them. That single failure was devastating for that entire unit. And that's the kind of engagement that we want to inspire.
Great. Thank you, Robin.
With regards to patients, one thing I'd like people to think about is educating your patients, but understanding that patients really do know more than they think they know. We don't have always the jargon, the medicalese, but I can tell you, if I'm a patient, 4 of my nurses came in and did the steps this way for my dressing change, and the last one came in and did it differently. What's wrong with that picture? They can tell you where the variation is. They may not be able to articulate the medical terminology for that, but they know something's different. They know when they see things that are out of place, or if they're feeling a different way after they've taken their medication 5 times in a row, and now this time it wasn't the same sensation, it was something different. But if we're engaging our patients and actually talking to them and using living room, average everyday language, we can get that kind of oral evaluation and history from them.
Tom, thank you, Alicia. Tom, Robin touched on the approach to improvement and how that's worked at her organization. Can you comment on how robust process improvement has benefited your organization and the approach there at Cedars?
Yeah, well, the whole, Mark described robust process improvement earlier, and that whole approach really matches up very well with the approach that we've tried to take at Cedars-Sinai for some time. And this, for us, we went through our own organizational evolution to move to this philosophy of zero defects. And what it does, in our experience, more than anything else, it causes you to look at the situation very differently. As Michael was alluding to, if you're shooting for an A, we're all trained from our grade school days that 95% is pretty good, right? That's an A. But if you say to yourself, no, I want to get to 100%, you think differently. So I'll just relay one story. So we've been driving our hospital-acquired infection rate lower and lower and lower and lower, but still not able to get to zero. And so as among the outcome, Mark talked about looking at each of the systems individually, right, and how they contribute to the potential problem. So at one point, the team that was looking at this in this particular case, something that applies in every patient's room. In every patient's room, there's a curtain inside the room, comes around the bed on a track. As we thought about it from the standpoint of zero, people looked at that curtain differently. They looked at the way it was mounted to the ceiling, and it happened to be mounted right up against the ceiling, which made it that much more difficult for people to change it out regularly. And then we cultured so people come in, they do the gel, and then they move the curtain back. So somebody said, let's culture the curtain. I don't want to tell you what's on the curtain in a typical patient room. And we switched to the antibacterial embedded curtains as well as part of it. And each of those steps put together ultimately get you, as Michael's organization, in all of the indicators that we've been talking about this morning, our performance has been at or near zero for some time now.
Sharon, what were the biggest hurdles that you faced as a board member when focusing attention and resources on the problem? What did you really face?
Well, as I said earlier, part of the problem at the board level, and most of us being non-clinicians, is that we wanted to come in and immediately just get to fix the problem. And as we didn't see the type of improvement we were expecting, we really couldn't understand why, and I'll use the example of hand hygiene. What's so hard about telling clinicians to wash their hands? I mean, coming from business, it just sounds like we know that these numbers, this is what will happen and how much money we can save. And being an institution very focused on that, we thought, tell them and they should do it. And it wasn't happening. Well, I'll give you a personal experience. At another institution, my 92-year-old father needed to be rushed to the hospital literally 2 weeks after we had this conversation, because I did not understand hand hygiene could be that difficult. We walk in the emergency room, and from that very point on, I had a different set of lenses. I can tell you to this day, the good news is he's 94 and he's fine. But I can tell you from this day, I learned by observing, because I was extremely pleased with his care. But I then knew what was possible. His emergency room bay had, not only a pump in there, but it also had a sink and soap. I did not see anyone use it. I saw someone come in, hang a bag, insert an IV, and then ask him his name, his age, his date of birth.
Oh, my gosh.
I knew it was wrong, but at the time I was so traumatized as to trying to figure out what was going on. And what I saw was that caregivers trying to figure out, okay, we've got a 92-year-old man, he's legally blind, he's got some health issues, what could be the problem? They were very focused on that. But what I didn't understand at the time, other than he can catch something, when I didn't see it occurring. The transporter, the first person that moved him from the emergency room to his room, wore gloves. I went, I get it. 6 hours later, when his primary care came in to do rounds, he walked in the room and hit the pump. I went, okay, I feel very good now. As he was leaving, I said he hit the pump on his way out. So it tells me it was second nature for his primary care. As he was leaving out, I said, thank you for doing that. And he didn't even know what I was talking about. He turned around and said, what do you mean, thank you? I said, for hitting the pump. And he goes, why do you know about that? And so I explained to him. And I came back to our chief medical officer, and we sat down at the table, and I said, okay, I get it. The board owns this. We will fix this. I now understand. That was a turning point, because then I had the passion to engage my peers at the board table about what we needed to do around hand hygiene.
Thank you. Robin, let's shift to cost a little bit. The cost of HAIs are tremendous. Talk to us a little bit about your work and understanding what you've learned at your organization about CLABS and how that compares with the solutions, the interventions. What have you learned?
Yeah. So we conducted a detailed return on investment assessment for our CLABSI work this year for our organization, because cost of care varies across the country, so mine will be different than his. Our average cost per case is a little over $28,000 for each of these infections. Over the last 5 years, by reducing CLABSIs, we've saved our organization in net operating income $7.3 million. We have invested extensively in interventions, in education, protocol development, communication, and structured performance improvement programs to drive down all hospital-acquired infections. This year alone, for CLABSI, in direct costs, not operational overhead, direct costs, we spent about $600,000, but our net annual benefit this year was $710,000. Over the last 5 years, our total return on investment for reducing CLABSIs is $6.6 million. It's worth it.
Mm-hmm. Absolutely.
Thank you. Yeah. And how has technology assisted your efforts?
Yeah, that's a great question. The best thing that we implemented, innovation that we implemented this year, was alcohol caps. For those of you who don't work in clinical practice, before a nurse enters the line, she must scrub the hub, that entry point, for 15 to 30 seconds. It's a lot of variability in that practice, because most times nurses don't actually put a stopwatch on and time that intervention. These alcohol caps keep the hubs in a pre-prep state at all times. So the nurse simply removes the caps and can immediately access the line. Our nurses, we've had nothing but positive feedback from this innovation that we implemented. And I will tell you that for those of us who work in quality improvement and patient safety improvement, we ask our clinicians and physicians to constantly do one more thing, one more checklist, one more this and that. And this was one time that we could give back to them, and they were so grateful. We had an unexpected positive outcome in that through this implementation and a couple others, we noted we had decrease redraws for contaminated blood cultures, further decreasing the cost of care.
Wow, so it just speaks to how broad and how the dividends can get paid when you use that approach. You find even more things that are improved along the way. That's fantastic. Sharon, you spoke about how the board, became aware of the problem and that they need to own, right, HAIs. But what can a hospital board really do to focus on the problem of HAIs? What are some concrete things that they can do?
So let's start with the board first needing to understand their fiduciary responsibility as to the patients and the people that they serve. People that come through our doors, that's who we owe. So, while you may have a lot of business people on the board, they really need to understand the issues. And as in any business, what gets measured gets managed. And so having the data that tells the story at a level that the board can understand and in a fashion that the board can understand really becomes a critical point.
Alicia, from a patient perspective, what can hospitals do? You've talked about a number of things, but if you were to really say, from my perspective, this is what a hospital needs to do to reduce their HAI rate.
Number one is compliance. Compliance, compliance, compliance. Compliance with hand hygiene protocols, compliance with infection control processes and procedures. I had several multi-drug resistant pathogens. I was never placed in contact isolation. There was a picture that you didn't get a chance to see of an in-service training for my ICU nurses where they're learning how to use the wound vac dressing change, and the center of my body is missing. They're all standing around me. No one has on gowns. A couple people don't have on gloves. They're wearing ties, jewelry, watches. That is so it's unreal in a healthcare situation where you're dealing with a patient that had as many things as I had. Then there were times when I was, they got me up to go ambulate the floor. Now I had 2 IV poles, one on each side. My mom would have one, my dad would have the other, and the nurse would be stabilizing me as I walked. But there were times when the fluid got to be so much inside the plastic that the seal would break. And of course, you can't turn a patient who's trying to save her leg and 2 IV poles very fast. So I would leave a puddle of just horrible purulent and serosanguinous drainage and stuff going down the hallway. And they would come with a white towel and wipe it up with their leg like that. And then other patients would ambulate with their socks and then get back in the bed. So we've got policies and procedures in place. We know what to do. We know about hand hygiene. We know about environmental services. We know what to do. We're just not complying with it. And then secondly, transparency. Transparency is one of the biggest keys to reducing and eliminating hospital-acquired infections, because if you don't acknowledge you have a problem, you are not going to work on solving it. If patients don't know what your infection rate is, they can't make wise, truly informed decisions about where they want to have their health care. So I would say compliance, transparency, and then providing resources, which is one of the reasons why we really have to engage our board members and our CEOs and the C-suite, because, for example, in my month in the med-surg unit, Patty, the wonderful woman who cleaned my room, was so embarrassed, and she came and apologized because she was cleaning my floor with a broken mop, like a Swiffer mop, and she had a white washcloth, like 2 washcloths, rubber banded to the end of the mop, and she was cleaning my floor with that instead of a real mop. I mean, it was, and this is a top-rated hospital. They funding, marble, koi ponds, meditation gardens. This is not a safety net hospital. And so when you don't allocate resources for housekeeping, for environmental services, for supplies, proper bandages, enough saline, enough lidocaine, you're going to have, Hospital-acquired infections will be inevitable if you're not doing these things.
Thank you. We spoke a little bit, or I mentioned the use of inappropriate antibiotics, giving antibiotics for too long, right? Increasing resistance across the healthcare system. Giving antibiotics, they're really a shared resource. They're not just for one patient. It creates an inability to even treat these infections. I mean, we take that for granted, but antibiotic stewardship is huge. It's a big deal. Robin, what has your system done? Talk a little bit about some of the approaches around antibiotic stewardship. How can we save more lives and decrease costs?
Yeah, this is antimicrobial stewardship is a community effort. You know, we have antibiograms that are, you know, tell you your sensitivities within your region, and so we need to come together as a community to tackle multi-drug resistant organisms as well as being good stewards within our organizations. We're doing a couple things. We have a lot of smaller community and rural hospitals within our system. So with the help of the Joint Commission and Pfizer that we applied for and received a grant for $800,000, we are currently testing 3 different models for supporting the small rural and community hospital who really doesn't have the operating income to have a ID physician and an ID pharmacist. So what can we use? We have telemedicine models we're doing, and as well as kind of a hub and spoke support system where you have a large tertiary hospital supporting several smaller rurals and working together as a community. We're looking at 3 different levels of support, the IT support it takes, as well as the human resources. And what's the minimum that an organization can invest in to get adequate antimicrobial stewardship out in the field, and so that we can prevent further mutations to these superbugs that really harm and kill people. And then from a multi-drug resistant organism, as we're working with our state and all of the healthcare systems. We're on committees. We're working with EMS on how we transfer and hand off and communicate from other level of cares into that EMS vehicle and then to the hospital. And then how are we cleaning those places as we do that transport? A lot of times we get these patients into the hospital and we don't find out till we've exposed a lot of people what kind of bugs they're carrying. So this kind of work, you cannot work in a silo when you're dealing with this. You've got to reach out and connect with your community partners. It takes the entire village, like they say, to tackle that one.
Thanks, Robin. We're going to just wrap up. Michael, I'd like to ask you just to give some advice to the audience here and to any hospital or health system that's just starting their journey, really, to eliminate HAIs. What makes the biggest difference? I mean, what should they do?
Well, that's a great question. The first thing I'd recommend is that they ask Alicia to speak to their medical staffs, and I'm going to. We have a medical staff retreat for all of our officers of our dozen hospitals and the medical staff officers and the chief executives and nursing executives. I'm going to invite you to address them.
And I did not
because
pay him. I didn't.
Yeah. So, because those personal stories, not joking, actually have a very significant effect. We start all of our board quality meetings with a patient story, either firsthand or with a video. And I've already asked to borrow some of the videos from this meeting because they're extraordinarily effective. I'm going to take it back to a basic common denominator. We've talked about it, hand hygiene. You will not be able to reduce your rates of ICU or floor or other kinds of infections without effective hand hygiene. We learned quite a bit from the Center for Transforming Healthcare, along with Cedars and many other hospitals, using the TST. We found issues in our hospitals we were not aware of, that well-meaning individuals like our dietary staff or our maintenance staff didn't have a place to put their things down to wash their hands to go into a room. And unique solutions, because of the TST, where it wasn't just about different hospitals, about different units in individual hospitals had different issues and different solutions, and we found those. I mean, and for some, we mounted alcohol gel dispensers on their carts that they move around, because then it's always handy. We wouldn't have thought of that before. So literally universal hand hygiene, and our current, we've been over 90% for a year, and our current metric, our goal for our executives, et cetera, is 95%, and it's not proportional. So if you're under 95, it's a 0. And that's one more thing. I think I want to just close with quoting Joe Kiani, who quoted the Stalin quote that you don't like to quote, that a single death is a tragedy and millions are a statistic. But when we show rates, and this is, we have to get our physicians weaned from this. They would say, well, we don't have many, it's 1 per 1,000 or 2 per 1,000 or whatever it is. It's the 1. We've taken away the denominator, the 1,000, and we just show, 1, 0, 2, whatever it is. That is powerful and effective, and that's a way to go forward for all of your HAIs.
Well, thank you all. Thank you.